We move on to our next speaker, Dr. Kumaradasan Umashankar from Sri Lanka, who will speak on the topic Conservative Management of Upper Tract TCC. Over to you, Dr. Umashankar.
Good morning to all of you. I will speak on conservative management of upper tract urothelial cancer. Introduction, the upper tract urothelial cancer is one of the rare tumors compared to the lower tract urothelial cancer, and it consists of only 5 to 10% of the urothelial cancer. However, the 90% of the upper tract tumors are urothelial cancers. The other 10% consist of squamous cell carcinoma and adenocarcinoma. Though it's rare tumor, the incidence is rising because of the better diagnostic techniques as well as long survival of patients after the bladder cancer treatment. In addition, the upper UTUC or the upper tract urothelial cancer has a significance because it has a poor prognosis and it usually presents late. 50% of the papillary and 80% of the sessile tumors present with the lamina propria or muscle invasion at presentation. And quickly go through the diagnosis. These patients mostly present with the hematuria and dysuria, and some patients come with a flank pain due to the direct involvement of the tumor, and also sometimes because of the obstruction of the tumor and the hydronephrosis. Also, these patients can present with the clot colics. 15% of these patients are asymptomatic and picked up with the routine imaging techniques. And these patients with the UTUC, usually the standard, we should go for the cystoscopy as there's coexisting bladder tumors. And ureteroscopy is a it's a technique where we can visualize the tumor directly, and also at the same time we have the chance to get the biopsy. However, there's a risk of biopsy and the ureteroscope because it has a sort of a seeding effect, and the risk of bladder cancer following ureteroscopy is high. To reduce that, there's a technique of giving one shot of mitomycin instillation following the ureteroscopy. For the tumors which are not accessible with the ureteroscopy or difficult imaging, we can do the antegrade endoscopic evaluation using the percutaneous technique. The other most important technique is the imaging, where the high resolution CT can pick up almost 90 to 95% of the urothelial cancers in the upper tract. The Houston value of these tumors are usually around 10 to 70 and average around 50. Because of that, the uric acid calculi, that is, which is usually Houston value is around 100, can be differentiated from the tumors. Cytology and tumor markers have questionable significance, as there's no proven or the effect on that because they have the low sensitivity and specificity. And now if you move on to the treatment of the upper tract urothelial cancer, the radical nephroureterectomy has been the standard or the gold standard of the treatment, because at that time there was no proper imaging techniques or proper ureteroscope or percutaneous scope were available, and because of that, follow-up after conservative management is difficult, and therefore only option left was for a more radical approach. But now with the new techniques as well as the new adjuvant therapy, the place for the conservative management of UTUC is coming. Now, what we consider as conservative management? The treatment, anything other than radical nephroureterectomy, is taken as a conservative management. The aim of this management or conservative management is to preserve the renal function as well as to reduce the morbidity for this patient. If you look at who are the patients who will be benefited from this conservative management, the most suitable patients are the patients with the low grade and low risk tumors. The patients with low risk and low grade tumors can go for conservative management with similar effect of RNU. And other patients are the patients with the unifocal disease and patients with the locally advanced disease. However, if they are not fit for radical nephroureterectomy or any other radical approach, then they should be considered for the conservative management. And as mentioned earlier, the patients with the renal function impairment or bilateral tumors, or patients who are potentially high risk for bilateral tumors with such as Lynch syndrome are considered for the conservative management. So before deciding which patient to go for conservative management and which patient to go for radical management, we should do the risk stratification of UTUC, and this is a simple approach. And this is a unifocal disease, tumors less than 2 centimeters, and these are the things we decide to, these patients in the low risk category can be safely go for the conservative management. And these are the patient and tumor-related prognostic factors. You can go through the age, ethnicity, gender. These are the patient factors, and stage, location, and especially location. When you consider the callosial tumors are more favorable for the conservative management than the ureteric tumors. Ureteric tumors also, the tumors in the upper 2/3 of the ureter have less favorable for the conservative management. And this is the treatment approach. Patient with the UTC and the low risk, then we go for the kidney sparing surgery. And also at the same time, even some of the high risk patients, when they are not suitable for the radical surgery or radical treatment, then they can come into the arm of the conservative management. Just quickly go through the modes of conservative management. These are the surgical methods which can use for the conservative management. One is the URS and the ablation and the resection. These are for low risk tumors, and also, but they should have the early second look URS, and they should have a good compliance and the stringent surveillance. Similarly, we can do the same thing through the percutaneous approach as well. And for the patients with the locally extended disease and who are not fit for the surgery or radical surgery, then we can go for the segmental resection, either open or laparoscopic or robotic. And in addition, we can go for the chemoablation. One of the standard methods is the mitomycin containing reverse thermal gel. It has a sort of a complete response range of 59% with biopsy proven low grade tumors. So it's basically the endoscopic management. We can do the retrograde, antegrade, or percutaneous resection. And the cancer specific survival is almost similar to RNU, and therefore this patient can be treated safely with conservative management. If in certain circumstances where the tumor section is not possible, then we can have conservative management and adjuvant therapy. So this is the 3 methods of the resection I have mentioned. There is one we call snare resection, or tumor resection using the resectoscope, where we can get the more complete resection, and other one is with the laser ablation. So these are the adjuvant therapies following the conservative management, but the use and the effect of these are still questionable. As the numbers are less, no proper randomized control trials are available yet. So after this organ sparing therapy, any procedure short of any radical surgery has a high risk of recurrence, and therefore the following approaches are adopted to minimize the risk. One is through instillation therapy, or both antegrade and the retrograde, and adjuvant systemic chemotherapy. This patient should be followed up with the rehabilitation and also followed up with the investigation, but the frequency and the type of investigation should be depend on the patient and tumor and the treatment modality. The low risk UTC we should go for the first look URS at 6 to 8 weeks, and then followed by CT urogram at 3 months. Then annually we have to do the follow-up up to the 5 years. High risk UTC, we have to do the follow-up even for more than 5 years.
You may now summarize, sir.
Yeah, thank you.